Hi, friends. Welcome to this part of T4. I'm so excited. We got to do a little live part, and now you're here in the pre-recorded session that I did with Kathryn Tullos. She is an RN. She's also a wife and a busy mama. She's from Houston, Texas, and I'm so glad that she's taken time. She had the night shift last night and woke up early in between kid activities, family activities, and her busy life. She has an associate's degree in nursing from Houston Community College and also a BA in communications from Brigham Young University. She was a bedside nurse in pediatrics for 7 years before taking a break to stay at home and raise her 4 kids, which she's still doing. She did return to full-time work as a patient advocate in 2015 with the nonprofit ITSAN, which is the International Topical Steroid Awareness Network, because she is dedicated to raising awareness about topical steroid withdrawal syndrome, a condition that affected her son. She is currently CEO and president of ITSAN, as one of the many, many hats that she wears so well. And I'm just so excited that she is here to share not only some of the science of these things, but to also just give us the patient perspective, what it's like as someone to live with this condition, what it's like to interact with medical professionals, how we can do a better job. So Kathy, I'm so excited you're here. Thanks for taking the time. And, I'll just let you kind of start with whatever you want to start with. What's the most important thing that you want to share, about topical steroid addiction and withdrawal and those kind of things?
Oh, wow. Well, first of all, thank you for having me and thank you for using your platform to raise awareness about this issue because so needed. I think where I want to start because of your audience being probably, medical providers, is that I just would like to say we need to believe and listen to our patients when they're reporting things that are outside of the norm. Um, it can be easy to think, to dismiss this, or when patients seem to be self-diagnosing, things like that. If we can just kind of like listen as if we're listening to a colleague, um, then we can get a lot more information that way. One of the barriers to diagnosing topical steroid withdrawal syndrome, I think, is we trust the drug more than we trust the patient at times. This is like a very safe drug. It has a 70-year profile. So, how can this be? But if you can just maybe, if we can keep an open mind that any drug that's safe for most people has adverse reaction possibility for a certain percent of the population. And so if we could just kind of stay open-minded and listen to what new symptoms our patients are experiencing. I know a lot of times in my personal experience with my son, who went through topical steroid withdrawal about 10 years ago, something that we came up against a lot was being treated like we weren't following instructions, like we weren't treating correctly. And that could go either direction. You're underusing, you're overusing, and even with my background as a pediatric nurse, I came up against this, oh, well, you're not using it right. Use it this way, use it this many times. And it's like, I'm telling you, I'm using it exactly as ordered. And here we are. This is what he looks like. It's not just not effective, it is spreading like wildfire, 10 times worse than before. So that's just, a jumping off point of listen to the patient and just keep an open mind. And I think when you keep an open mind, your patients are more willing to keep appointments, to come back, to trust you. If they feel dismissed, especially in this patient population, it just breaks down that relationship. And then when they really need you, um, they've gone rogue. And sometimes in patient groups, they ask each other, they diagnose each other. And I think that's a very unsafe dynamic as well, because sometimes you can have infection. You can have things where you really need a doctor. You don't need each other at that point. So yeah, that's where I would begin. And let me know,
Yeah,
Yeah.
no,
Want me to
that's so perfect. I will tell you
okay.
that is a perfect place to jump off and start with because, I hope that going forward, part of the reason that we are doing this T4 series, especially with the patient perspective, is so that future healthcare providers and even current healthcare providers that might be listening can do a better job. Like, we don't know what we don't know. And once we know, we need to do better with what we know. So again, I think a lot of people just haven't been exposed to this in the right way, maybe, or, have gained an understanding. So I think it's so important. And I think with all patients, but especially your patients that are struggling, it's so important to build that therapeutic alliance. Again, we have such a
Yes.
privilege and a gift to take care of patients. They come to us when they need us. Otherwise, why would we exist, right? Like, so why did we go through all this training? We did all this training, went into all this debt so that we could take really great care of patients and help the patients, which then helps us, and it's, a
Yes.
win-win. So again,
Yes.
I hope all of our T4 listeners are going to go out and change the world. And I do feel like they are. Some of the younger generation really does care and they really do listen, I think, a lot more than, maybe the old guard that is more dismissive. So again, I
Right.
have a lot
Right.
of hope for, the
Yes.
future going forward. And you guys as an organization and as a community have done such amazing work to get the word out. So, it's
Thank
incredible what you
you.
guys have done and what you've recognized and what you've put together as a community, because it is sometimes, not obvious if you're just kind of seeing people in a vacuum, but you guys have come together and almost given it to healthcare providers on a silver platter. Like, this is what you look for, this is what you need to do. And, please work with us because we want to work with you. And again, that therapeutic alliance is key in patient care, regardless of what the diagnosis is. So thanks for bringing that up because it is near
Yes.
and dear to my heart. So as far as what you've learned on your journey, as what is something that I guess maybe share, uh, let's start with a negative experience that you had that you can just give us an example, because I think people's stories are powerful and you clearly have a story that led you to this point in your journey.
Yeah. Yeah. Absolutely. So I'll just kind of give a little background. So I have a background in pediatric bedside nursing in the hospital setting, and I have 4 children, and I grew up with eczema. I come from a family of also 4 kids, and we all had eczema. And so when this whole thing started happening to my son, he's my third child, it was really obvious to me that this wasn't typical eczema anymore. Even just from like a clinical standpoint, if I was just an observer, like this is different. So my son was prescribed topical steroids at 6 months old. He was diagnosed with eczema. Looking back, the steroid that he was started off on was not approved for his age. It said 2 years and up. It was a moderate to high potency. Nowadays, we're seeing babies being prescribed all the way up to clobetasol right off the bat. Very high potency, not approved for their age. So there's kind of a lot of off-label going on, and we know that babies have that high surface area to volume ratio, so they absorb a lot more. Their skin is thinner, so you have the young age, the surface area. I mean, it's kind of like this perfect storm to overabsorb these drugs if we are prescribed high potency. So let's just keep that in mind. So 6 months old, and at first the steroids worked exactly how they should and exactly how I always seen them work in myself and my other children. You could use it for a couple days, everything cleared up, and then he had clearance for I don't know, a week, sometimes 2, and then would cycle would start all over again. Sometime around when he was, I guess, maybe he'd been on steroids about 3 years. So he was 3.5 at this point. We just started chasing it all over his body. It wasn't in his typical areas. So he had very orthodox presentation, I would say, originally, like skin folds and, around the wrist and his feet and hands, and sometimes his little cheeks. But that was that. And this started to kind of like spread up his arms. It was started to be full leg, hip to toe. His face, which we never really had problems with, started to be involved. It just was spreading. So we're having to chase it to new areas. That was the first thing. And then we had to treat way more often. And his breaks were getting like shorter. And so when we're starting to have to use almost without breaks, that was kind of like what's going on. But really what was the huge tip off was he just started burning and everything was stinging, like trusted moisturizers that we'd been able to use this whole time. It was, I mean, it was like he was on fire. And then it started to get to where like his bathwater was burning. And then it was just all the time, the air, he couldn't even wear his clothes. He was little, he wasn't in school, so he could kind of run around that way. But it's like, there's something off here. And the look of it was very, very different. It was very like flushed and almost like a sunburn. It wasn't, the patches that you're used to seeing with eczema. It's like you have patchiness, but this was like, I guess they call it confluent, right? Um, so like this has shifted. So that's kind of when I kind of like took to the internet and I was looking for good information, like peer-reviewed research. And there was a little bit out there. And I was like, okay, this is what I think is going on, that he's having this kind of like addiction withdrawal cycle. Especially, like with the stinging and the burning and just like the new symptoms and all of that. So I took the information with me to doctor's appointments, and I was like, I think this is what's happening to him. And the first thing I Googled was steroid resistance. I wanted to put that out there because that's what it looked like to me. Almost like an antibiotic resistance. I know it doesn't work the same, but it's like this is not working. We're having to use more often, without breaks. This is not, so that was the first thing I was Googling, and I didn't get terribly far there, but little bunny trails you follow, and I kind of found a handful of peer-reviewed articles. And so I would take it into doctor's office with me. We kept on getting referred to different specialists at this point. So pediatrician was like, this is kind of, above my pay grade. And so we went to a pediatric derm and a pediatric allergist. And neither one of them were very interested in the literature that I brought with me. And I think it was off-putting to them on some level that, I Dr. Googled and I don't know. So it wasn't a great dynamic. The allergist was probably the worst interaction. I found out later because I went and got all of my medical records that she wrote that his condition was due to mother's mismanagement of eczema, right? That was a good one. And when I was telling her, I think that this is what it is and all the reasons why, she's like, I do not think so, but if it is, then let's write him up as a case study. I was like, okay, well, fast forward to when we withdrew off steroids. It was, like a year and a half of pure hell for him, but he did clear up and he stayed cleared up. I circled back around with her to tell her that, and she said, I do not recall the conversation you report. So missed opportunity. She had a case study right in front of her, and I took so many pictures and I documented everything because I didn't know if I was right. This is so new. All I'm doing is reading the literature and having a gut feeling. And we had reached a brick wall with the steroid treatment anyways, because he started to have other side effects that children sometimes get when they use too many steroids. So his growth was stunted. He got a new murmur in his heart. We had to see a cardiologist, and she said that he had a thickened heart wall from the steroids. And I was like, I've never heard of that. That's actually, I don't hear of that much in the groups. That's a very rare thing within our community. But um, so between the endocrinologist and the cardiologist, they're like, he can't use any more of this stuff, and so I kind of had a leg to stand on there about stopping steroids. But this is 2013, 2014. There were no alternatives. There were no biologics. You're talking cyclosporin or methotrexate. That was it. Um, so sometime around the time that we decided that, my husband and I, after we took in all the opinions of specialists, that, okay, we have to stop using this because the only way out is through, kind of thing. He started to get MRSA infections. So then he's being seen by infectious disease. And part of stopping steroids for a lot of people, your lymph nodes blow up all over your body. So he had a lymph node biopsy. So, I mean, he was just seeing everybody because I wanted everything ruled out. And so, yeah, so it just wasn't, nothing else was showing up. We even had him genetically tested for hyper IgE syndrome, because that's another symptom you see, is the elevated IgE level. It's like 12,600. I mean, like through the roof, crazy levels. But yeah, we decided to go that route. And when we were treating him with antibiotics because of the recurrent MRSA, and that was something where I can't see putting him on these immunosuppressants when he's getting infections so often and they're so severe. So it's really just kind of like, what gets you through the moment and causes the least harm, and that's it. Because some of these medications, it may solve one problem, but then you're dealing with a set of new problems. And so, that was kind of just what we did. It was comfort measures. And I mean, the withdrawal phase, he was bright red head to toe. He didn't have a clear patch anywhere. And he was sloughing skin off, where this is like a common not side effect, but just presentation for most of our TSW people, where it literally looks like wherever you're sitting, if someone like shook baking soda or something. I mean, I had a vacuum dedicated to his bed only because he still napped. He was little. So twice a day, I'm vacuuming his sheets. And then once a day, I'm laundering them. Um, because, he's at that point, he was kind of mummy wrapped. We're using Vaseline. We're just doing whatever to keep him comfortable. For some period, he could tolerate baths, and like some people in our community live in the bathtub, some people can't. He wasn't tolerating baths for a huge part of it. And then we just treated for infections. We treated for itch as much as we could. We had like Atarax and Benadryl orally. But around month 9, I'm going to say, off steroids, I feel like we turned a corner and he started to have more clear patches than red. And for him, he started clearing up from his trunk out. So I'm not quite sure why that is, if it's a lymph system thing. I don't know, but his back and his trunk cleared up, and then the tops of his arms, the tops of his legs, and it kind of spread out to like hands and feet were last, and like his calves and everything. And so around month, I'm going to say 14, we were approved for a at-home phototherapy unit by prescription. And so he was, I'm going to say 80% clear at this point, just from, I think, just time passing. But he was still, extremely uncomfortable, because 20% is still a lot, to deal with. So we were doing the phototherapy 3 times a week for 6 months. And that actually, at the end of that 6 months, he was crystal clear and he was comfortable. And so then you're kind of, it's always that cost benefit. So we're like, okay, well, let's back off of this and see where we land, because he was still 4. So I'm like, it's still radiation, So where we landed was where we started, with typical presentation of eczema, sometimes in your typical places. And sometimes he was totally clear. So we just kind of cycle. So we're kind of left with, he, if I knew from the beginning, would we have made the same choices? Because compared to TSW, it was so much better. Like the little typical patches was doable, manageable. He could live his life. He could run around and play. He started kindergarten with no problems. Now he's 15 now, and he's my most active child. He's on the football team. He doesn't have skin issues anymore. So this was another thing. All of his problems resolved within 2 years of stopping steroids, all of them. We were discharged from cardiology services. She followed him for 5 years, actually. At the end of 5 years, she said he had no problems. His heart looked normal. So whatever that problem that was being caused was reversed. We were dismissed from the endocrine. We're dismissed from infectious disease. I mean, it was just kind of like one by one, all those problems went away. And still, from pediatric dermatologist, she just said, I guess he just grew out of it. Like, okay.
Oh, sweet mama. Sweet mama. I am so sorry. I apologize for my colleagues. I do. I I want to cry for you as a mama, um, as a care provider, and again, health care provider. And I'm sorry. I'm sorry you had to live through that. I'm sorry your son had to live through that. And I'm so sorry that these TSW warriors are living through it. But the good news is you guys are warriors. And, you have raised awareness. You have beat the bushes. You have started a movement. So congratulations for taking the pain that you experienced and using it for a purpose so that others don't have to go through this, and for raising your voices. And sometimes, unfortunately, when you're not being heard, you have to raise your voice louder. And that can be alienating, especially to a medical care provider who feels like they know a lot.
Yes.
And it's like trying to mix oil and water. And that breaks my heart because, again, parents' intuition, patients' intuition, you guys live in the skin that you were, born with and given. And you guys, patients, are our best resources of information. And yes, maybe they're going to get it wrong every once in a while and go down a rabbit trail that's not true. But
Yeah.
it's all about building that therapeutic alliance and listening, and not just dismissing everything that a patient says or a parent says when you have a pediatric patient, because really that is the most valuable information we can get. Aside
Yes.
from, and then walking that path and that journey together to figure it out, because just like you said, you do need medical care providers.
Yes.
And I
And
think,
I literally told
yeah,
them, this is the only thing I'm not willing to do anymore. And I reminded them, I tried it your way for 3 years, and this is where we landed. And we did do it. We did wet wraps. We did the whole thing. We hit it hard. And so that's what I, tried to find that common ground. Like,
right.
I'm just stopping this one thing because we haven't tried that yet. And I literally said, let's do it for a year. Let's do it for a year and just see what happens. And if we are still so bad, then we'll go back to do it your way. But literally, when I'm trying all this stuff and the different creams and therapies, And this is the one thing I haven't tried that's in the literature. Um, and I want to treat his infections. I want to treat, sleep, anxiety, itch. Like there's a lot of symptoms that we can work together on that you need help with. You need help and support medically because it's terrible, and it's terrible for the patient. It's very dangerous to go it alone. So I think, that's also my advice for patients is, you know, meet your doctor halfway, like have a middle ground where it's like, this is the therapy I think is the problem. So let's not with that one, but what else can we do? Let's work together on this.
Yeah, and I think you're right. I do think that the therapeutic alliance is huge, and some docs just are not going to listen. And you may have to physician jump a little bit, which kind of gets patients a bad reputation among the medical professionals, unfortunately. But again, I think most people are reasonable and would listen. But I've heard too many stories to know that's unfortunately not true. And so, yes, there are some patients out there that are physician hopping because they may have a mental illness in addition to their skin illness. And again, that still needs to be addressed and treated appropriately. But there is a subset of our patients that doctor hop because they're just not meeting up with people that are willing to listen and work with them. And I think that is a missed opportunity, just like you said. And again, I'm just so glad this is coming to the forefront, and there are more medical providers, more dermatologists that are willing to look into topical steroid withdrawal, topical steroid addiction, because it is a subset of people that I think are prone to it. And I do think, like you mentioned, I practiced for 20 years and I started in the dark ages of atopic dermatitis. I mean, there was so much we didn't know. And, that creep up of the atopic march, and more people are getting it. And finally, and again, a lot of it is driven from the pharmaceutical market in some ways, because they have to have that data to drive forward therapies that can make money. And finally, I think a lot of skin diseases have been hidden because people have hidden in the shadows and given up hope and not come forward, right? So I'm so glad that we have come out of the dark ages for atopic dermatitis finally, because it's too big of a
Yes.
patient subset to not
Yeah.
study really well. So we're learning more about the pathophysiology of it. And I do think this topical steroid, this subset of patients that have this potential for addiction, or the potential, whatever you want to call it, for side effects, or it's not a true allergy, but an allergy, or however you want to coin the phrase that makes it palatable.
Yes.
And that's the thing. I think sometimes it's just the way it's presented cannot be
Yes.
palatable.
Yes.
And then the terms we use to describe it, just nobody wants to accept that. And I think
Right.
it's really, again, first, do no harm, like you mentioned.
Right.
Doctors really don't want to harm anyone. Deep down, they don't.
Yeah.
But they're tired, they're overwhelmed, they're getting it hit from every angle, right? And it's not an
Yeah.
excuse, but there's just certain triggers. And unfortunately, an angry patient, which patients with TSW have every right to be angry,
Right.
because
Right.
you're in a terrible situation and you can't get the help that you need. So again, if we can all just kind of come to the table, take a deep breath before, as a patient, go in as best you can, and you did that, you still didn't get the results you want, but come in, approach it. But then every physician needs to stop at the door before they knock, take a breath. This is what I did. Say a little prayer if you have to, say a little phrase, remind yourself that this is somebody's mother, brother, sister, son, daughter,
Yes.
could be related to you. And I think if we then meet in the exam room where we've
Yes.
kind of come in with level heads, we're going to get a lot more from
Yes.
the conversation that we have, and looking at it as a
Because
conversation.
even if it was a conversation, that would have meant so much because sometimes it's just like someone is dictating to you. And
Right.
one of the other things I wanted to add was this notion of steroid phobia. That's something that's thrown at our community a lot. And I'm like, I had no reason to not trust this drug. I'm a medical professional. I saw it used successfully up until my son. And so it's not steroid phobic when you are actually seeing side effects and you're actually feeling pain. I would I would think steroid phobia is I haven't used this drug and I've heard bad things and so I'm not using it. But this is all of these people use the drug. They weren't afraid of it, opposite. So
Yeah,
when they're actually seeing these side effects, that term needs to go away. And it's the minute a patient hears that, it just shuts down the relationship. And so and I just think like now that we're kind of moving forward and trying to get a diagnostic code, we're trying to set up a patient registry, we're trying to get things added to labels. Hopefully that will become TSW will become a little more legitimized, because
right,
it's really difficult to be treated that way. I know still 9 times out of 10 patients are told this doesn't exist. It's an internet myth. There's so much misinformation, and there is so much misinformation. And I think that's why I was maybe a little more successful in my visits, which still wasn't great, but a little more than most people in the community, because I did have a background. I came with peer-reviewed studies, good information to bring
right,
to the table, and just curiosity. That's all I wanted out of his specialist too. Just a little intellectual curiosity, like,
mm,
let's say it is the drug. Let's just experiment, right? What
right,
would it look like and how would it go? And um let's just go there for a second. Even if you can't accept it, like let's just be open-minded, because these people deserve it. And
right,
there's a lot of things that look like TSW, and this is what scares me, that people go in these groups and they're like, okay, you know, I have TSW and everything is TSW, and everything's not. It could be any number of things. You have to rule out everything else because it's so new. So I think it's still definitely a diagnosis of exclusion. So we need that patient doctor relationship to be open and to be able to bounce ideas off each other, and to be believed that, like, I really did use the medication this way. I'm not underusing. The only reason I stopped is because we had such bad side effects.
yeah,
And why would you tell someone to use something that caused them problems? You would do that if you didn't believe they had a problem. So, that
right,
that basic lack of trust, it just stands in the way. So the work we're doing hopefully will continue to legitimize as we, publish papers and things like that. But even just to open up the curiosity, even just
right,
to say, what if? That would be definitely
right.
a step in the right
I
direction.
I think that is a great tip. The just what if? And again, that's important as a medical care provider is if somebody is getting worse or not getting better, you have to in yourself as a healthcare provider, a physician, a dermatologist say, what is going on? And non-compliance is something because atopic dermatitis care is hard. And in the dark ages, before we had some of these better medicines that were actually remittive and helpful, and what we ask our patients to do, I always would say this when I talked about atopic derm, and I'm so glad that we're, talking during Atopic Dermatitis Awareness Month or Eczema Awareness Month,
Yes.
because what we used to ask patients to do, I'm like, think about it, y'all. Like when some of my colleagues would complain that patients didn't do things, I'm like, I think most of the time they are, and maybe they're not doing it to the exact letter of the law. But if you think about it, I'm like, I would come home and kind of sniff on my kids when they're little and be like, are they stinky? Do they really need a bath? Like that kind of thing. But parents of atopic dermatitis you don't have that luxury. You have to be dedicated to their skincare. You have to put them in the bathtub. You have to do all of these things. And you don't want to do that, but you do it because you care, because you want to make a difference. And so I think what we use and wet wraps, yes, they can be very helpful. And I do recommend them and I like them. But they're not easy. We have to acknowledge this is not easy what we're asking these families to do. Because again, it's easy for us to sit at our computer, do this, do this, do this, and then give them a piece of paper and say, okay, now go torture your child by dunking them in the bath while they're screaming. Now pull them off of
Yes.
their sheets in the morning when they're bloody and stuck to their sheets, or don't sleep all night because you're listening to your kid scratch, scratch, scratch down the hallway, or cry, or scream, or all of those things. And
Yes.
it's a family disease, if you will, because it affects everybody in the sphere, even the siblings, right?
Yes.
Um,
Yes.
because they
Well,
hear it too. And I think that, again, it's got so atopic dermatitis is a complex disease anyway. And yes,
yes.
luckily there's things in the pipeline that are better. There's things that aren't immunosuppressive, that really are targeted more to that inflammatory cascade that we know gets kicked off. But then we do have to keep an open mind and have that intellectual curiosity. And,
Yes.
I mean, I do think that there's going to be a subset of physicians that come forward and really champion this cause, and do the research. And I
So,
see the glimmering lights. And again,
yes.
you guys have kind of started that fire, and lit that flame. So thank you for doing that, because we do need more science behind it, because it is a
Yes.
very real disease. And when you see it, it is different than atopic derm. The other thing is, again, going back to, you have to run your differential diagnosis if a patient's not getting better. So you need to think about those other things. Like, again, there's, T-cell lymphoma, Sézary syndrome, that can look
Yes.
like topical
Yes.
steroid withdrawal.
Yep.
And that's the one that I'm sure you were referring to,
Yes.
that needs different treatment and different specialists. And so that, can be the thing. But allergic contact derm, and that was something that was
Yes.
dismissed for ages, that, oh,
Mm-hmm.
kids can't get allergic contact dermatitis. They can get allergic contact dermatitis. And the thing is, so many patients have gone off the grid when the topical steroids aren't working and they're not getting
Yes.
answers from medical professionals. Then they're going to delve into things that are outside the box.
Mhm.
And outside the box doesn't always fix things either. We know that. And sometimes they
Yes.
can cause more complications. And again, so
Well,
I think it's really important when things aren't working to always be reevaluating. Don't
yes.
cut and paste the medical record and give another tub of topical steroids. Like, please stop. Please.
Well, and yes, and we were patch tested for contact dermatitis, and there were things that came back that he was sensitive to that I had no idea. And like lanolin, for instance, because we use this on, it's a breast cream, it's
Right.
gentle for baby, and a lot of products have it, and it's safe for most people, but my son reacted to it, and once I eliminated that, he improved a lot. And I felt so bad because I was putting a lanolin based product on all his bad patches. And then it was like, that's why they're the bad patches. Because when we stopped using it, he cleared up by a ton. And I was like, what if we started there? Instead of just, here's the topical steroids, what if we started with what are the triggers? What if he was tested first? Because we had to wait a long time until his back was clear enough to even test. So it's
Right.
like, this is way after the fact of all the suffering he went through that we could even do that test. The other thing I want to say is, TSW doesn't happen to everyone who uses steroids, but it
Mhm.
happens to some people. And so the people who it happens to deserve to get a proper diagnosis and deserve to be properly treated. And the truth is, we have a ton of questions surrounding topical steroids. They're not prescribed with a dose, for one thing. They're prescribed on affected areas as needed. You have a nod to a dose with the fingertip unit, but you're
Right.
never told how many fingertip units per day is a maximum. Like in pediatric nursing, we have, with your weight and your age, you have a max dose for everything.
Right.
But this doesn't have that. So to point fingers at patients in any way to say you're underusing or overusing when we don't even know what the therapeutic dose is. It has not been studied. We know a little bit about if you use on more than 20% of the body, blah blah blah, HPA axis suppression. We know a
Right.
little bit around that,
Right.
but we don't really know, what the safe parameters are. Um, and we don't prescribe it. Like, something I wished, looking back, was that there was some, even like a checklist, an app, anything that was like, how many times a day are you using this? How many times a week? How many fingertip units? Like, just track it, because I think my doctor thought the refills were tracking it. So she could say, okay, you refilled this many times a month. That means you had this many milligrams, whatever. But that was just her. We had an allergist, we had a pediatric derm, we had a regular pediatrician, all prescribing. We had his siblings had the exact same prescription, so we're funneling that over to him. The other thing is, there's like a cumulative thing happening when you have steroid nasal spray, steroid inhaler, eye drops, nebulized steroids. I mean, some of these kids, especially with the atopic march, they're on steroids of all kinds for their
Right.
allergies, their asthma, and then topically. So, you could be totally overdosed, but again, we don't know the definition of overdose and nobody's tracking it. So, if we could have tracked it in some way,
Right.
and nobody tracks it. But if we could have, I think my physicians would have said, "Oh wow, you're using a ton of this stuff," instead of, "Oh, use a little more, use it," like, not believed that we're following, the protocols. Um,
Right.
so nobody knows. Even with our patient registry work or any surveys that we've done, it's almost impossible to collect that information of how much did you use. And in our process writing papers in the peer review, they always
Mhm.
want to know that. Well,
Right.
exactly how much? And it's like, you don't prescribe it that way. It's not this many teaspoons, this many times a day. If it's not prescribed that way, how does the patient have nobody's tracking it, you're not tracking it, they're not tracking it, there's not a tool for that. Nobody knows. It's all
Yeah.
recall bias. You can kind of guess, but until we have more precise way to measure and to collect that kind of data on use, it's
Mhm.
all a big guessing game. And so that has to be acknowledged, that we don't know what we don't know, right?
Yeah. No, I
So
think that's a perfect point. I think that's a perfect point to bring up because again, when I was, and there is that subset, and again, the words we use are important, semantics are important, and there are that subset of patients that have never used topical steroids and they do have a, they're scared of it. They're leery of it. And I do think that the messaging around topical steroids because we don't want to lose something in our armamentarium that could be effective. And I think really starting with the least amount, the least potent topical steroid, the least amount to get you clear, and then knowing what that is, and then also doing steroid holidays where you tell them you can't, as needed should not be written on any steroid. And I also hate the tubs of topical steroids because they get contaminated. That's where MRSA
yes,
comes from, because we know that people are colonized and they're putting it on, they're sticking
double
it back
dipping.
in the tub. And that is
Yeah.
I mean, it's just a big petri dish of staph. And again, if you haven't been told that, you wouldn't know. And I've had
Right.
patients that had been going to ID and trying to figure this out and on all these really strong antibiotics that totally screwed up their skin microbiome, their gut microbiome, which we didn't need to be done. And I'm like, are you putting your hand in the tub that you've been
Yeah.
prescribed? Um,
We had plastic spoons and paper plates. I mean, we were just, I'm telling you, it was crazy just to like eliminate any of that. But I wanted to say one more thing on steroid phobia, where when you aren't given informed consent, and then when you have a side effect, you're not believed. I think that people have a right to be concerned, even if they've never used steroids, because they're seeing what happens to people who do. They're seeing that they're not believed when something happens. And so it's kind of like we have to come together on this to realize, there's a difference between steroid phobia and true concern, because they're seeing this happen to my friend and then they couldn't get care, they weren't believed. So if the patient is trusting you enough to use the therapy, as you say, you have to be open to the therapy not working and acknowledging the patient, whatever they're reporting to you. And they should be educated on what the possibilities are. That's informed consent. So I think that's another, gap we can bridge together.
Absolutely. I think that's a great point, a very good point, because again, we don't want to throw out the baby with the bathwater kind of
Right.
thing. But for the people that are experiencing this, it is hell on earth. Um,
Right.
it is,
Right.
and that's not fair. And again, I do think genomics and all of these things are going to move that science forward too,
Yes.
where we can look at a patient because there's certain medicines that we check, certain levels. And if people don't have a certain level of an enzyme, we don't give this medicine. And maybe it's an enzyme problem, or maybe it's the way that it's, again, like we think
The
of
med is processed.
nerves or the blood vessels or, those things, because there has to be a reason. It's not made up, and
Yes.
there's enough data to show us that there is this phenotype of topical steroid withdrawal that's different than atopic dermatitis,
Yes.
different than some of these other differential diagnoses, if we open our eyes to it. But if we keep our eyes closed, we're not going to be able to see. And if we,
Yes.
and you can hear things, but you need to listen. There's a
Yes.
big difference between hearing and listening and looking and seeing. So again, I think we need to keep our eyes and our ears open and partner together. I think that's so
Yes.
important. And an app is a lovely idea. Like developing an app. And again, it makes it easier on the physician. You don't have to sit there and calculate how many
Right.
steroids. And when I was giving steroids, I would ask my patients, if especially if they were concerned about topical steroid and they hadn't had any, I heard them, I listened, because I'm a parent too. You want to wrap your kid in bubble wrap and not let
Yes.
anything damage them, but you
Right.
also see them suffering from their eczema, and you don't want them to suffer either. But you feel like you're in a no-win situation sometimes when you have a kid with eczema, right? So I
Yes.
think that would be lovely, but I would ask my parents, please let me be the only one prescribing the topical steroid. And
Oh,
that
nice.
is what I would ask my
Yeah.
patients. I'm like, I know you can get it from your primary care doctor. I know you can get it from your allergist. I know you can go to the ER and get it in urgent care. I'm like, but then we can't follow it.
You
And
can't monitor. Yep.
really monitor. So I really did. I'm like, if I'm going to prescribe it, I want to be the only one. And then I would ask them how much of their, I love the oil. Because
Hmm.
it's a low potency. It's been looked at in young kids. It's easy to smear on. The oil of it, again, it's in peanut oil, but the part that is antigenic has really been filtered out, as long as you get the brand. Um,
Hmm.
and that doesn't usually burn and sting, because again, I don't want the treatment to be worse than
Right.
than the
Right.
disease, right? So,
Hmm.
um, I used a lot of that because it was low potency. Um, and then I could figure out like how much your bottle, and I would figure out how much they used and how many days per month, like every time I came in. And this is partially because I had a great mentor, Elaine Siegfried, who does care about how much topical steroid, and she was at the forefront of fingertip units and always talking
Yeah.
about these things. Um and I do think that is a great idea, really, to partner on something like that, because it would be valuable information, just like we figure out how much cumulative dose of methotrexate somebody's gotten. We used to
Right.
keep that as a running
Right.
total in the chart. Like, what is the running total of grams of topical steroid exposure, and capturing that from the beginning, because you're right, that recall bias is hard. And
Nobody knows.
yeah,
Yeah.
and again, sticking with one provider, because again, sometimes people are so desperate that they'll go to a bunch of people, and they almost become like drug seekers for their topical steroid too.
Mhm,
And that's
mhm.
hard too as a medical care provider because there's those people out there as well. And I did see kids just getting pounds of topical steroid prescribed to them. And I will not put it in a jar. I will not prescribe a pound because then people think it's not a drug. They think it's their
Right.
moisturizer and then they're
Yes.
moisturizing with it.
Yeah.
I hate the tub of topical steroid because again, it gives you way too much. It can
Mhm.
get contaminated way too easily, and it can be used so inappropriately, like put it in
Yes.
a tube. And again, if you think a patient needs 4 tubes, then say dispense 4 tubes of 45
Yes.
grams, and then it doesn't get contaminated. And then you are the only one prescribing it. So you can kind of figure out, since I last saw this patient, and I
Yes.
say, let's stick to the moisturizers I want you to use because I know you have a whole cabinet full of topical steroids. And because of this delayed reaction of these allergic contact
Yes.
dermatitis, we have no idea what triggered it
Yeah.
because
Which thing?
what
Mhm.
you used last night probably didn't trigger it. It was probably the thing you used 2 or 3
Last
nights
week.
ago
Yes.
or last week.
Yeah.
Um, and so
That's
stick with my
such a good
regimen,
point.
which is going to be very simple, simple baths, simple, cleanser,
Mhm.
simple moisturizer, and a cream or an ointment. And as long as you stick with that with me, we'll prescribe the topical steroid, we'll see how it goes, and then we can kind of reconvene. And early on doing patch testing, I think that's important. You don't want to put a kid through patch testing because it's not fun, it's not easy. There's not a lot of healthcare providers that will even do patch testing in a kiddo.
Mhm.
But now we know some of those allergens because the science
Yes.
on what allergens are more prevalent in peds and a smaller defined patch test now is out there. So
Mhm.
colleagues have brought that science forward too. And you don't want to put a kid through any testing, a biopsy, a blood draw, patch testing. You
Right.
don't need to because sometimes insurance doesn't pay for it and it's expensive.
Right.
So I always, if topical steroids started not working, kids were getting worse, new areas were developing, or they were needing more topical steroids or higher potency to get under control. That was always my trigger for contact allergy, especially
Mhm.
if you had, because areas that love allergic contact dermatitis are around the eyes, around the mouth. Um,
Mhm.
and again, that's also a place where topical steroid withdrawal can be. But I think in that subset specifically, the first thing we should do is get patch testing
Yeah.
before it just gets out of control where you
Yeah.
can't do it. And then you get the whole angry back thing. And then what's a real positive? What's a negative? Because it's
Yes.
so reactive at
That's
that
why
point.
it's that's why it's
Yeah.
helpful, in my opinion, as a first step because you're clear still,
Yeah.
usually. And the
Yeah.
patch testing for my son was like nothing compared to a skin prick. Like a skin prick's painful. Patch test, it's stickers, and then you leave it for a day, pull it off, come back 2 days later, they look at it. So, to me, it was a pretty benign test as far as tests go. I wanted to go back to one of your points about patients thinking it's just a moisturizer. And this is another thing we're trying to push with labeling is label that it's a steroid. Because
Yeah.
even in the groups, people are like, is this a steroid? What is this? We still don't have that basic labeling. Like, what is this? The other thing is the potency thing is so confusing because you
It
have
is.
these little decimal points and percents. And so you could have like a 0.025%. And that sounds like very small, but if it's of like a clobetasol or a betamethasone, it's not. It's 600 times as potent as over-the-counter hydrocortisone, which is 1%. So make it
Right.
make sense, right? So there's so much education around that. People have no idea what they're using, or in the hierarchy of things, how potent is this? And kind of like this, well, if a little is good, more is better. And it's just so much education we need around it. Another thing I wanted to add was about like terms of addiction withdrawal are very off-putting.
Yeah.
Even when we're trying to get our diagnostic code, there's so much pushback because I guess within the diagnostic code system, it's used for substance abuse. And so they don't even want those terms tacked on there. So we're having kind of a time with inclusion terms and everything. But if you think of it like an addiction, if you can just think of it that way, because this is how it presents. It's helpful because, of course, if you're addicted, let's just say to street drugs, of course, when you quit the drug, it's horrible. You're in crazy withdrawals. It's terrible. Would you say to that person, you were better on the drug? Go back to using. You were better that way, right? No. And you get through it, and then you are back to better, than you began. And the other thing is, that escalating use. Like for my son, that was another tip off. It was like, I'm not treating your eczema anymore. I'm treating what happens when we don't use the steroids. Because you go a day without and he's flush bright red. So you're treating what happens when you don't use the drug. You're not treating the original eczema anymore. And
Right.
so, and for my son, after he went through the withdrawal phase, he went back to normal and he's clear probably 90% of the time. I would say in the spring, sometimes he gets patches, but they're patches behind his knees, maybe on his ankle or his wrist, and then they cycle and go away. Some people we're seeing have, and probably Dr. Leo will talk about this, it seems to be damage because some people use for 30 years plus, and there's some kind of something that got tripped up. Like for my son, it took almost 2 years, and it really does take that long, which is hard. So, you're seeing doctors who's like, well, your withdrawal isn't working. And it's like, I know it looks that way. So that's another thing we have to get on the same page about. It is protracted. It really does take that long. I don't understand why. Lots of question marks around that. Is it, your adrenals? Is it because you have the skin is involved, you have hormone involvement, and you have immune system involvement. You have all of
Absolutely.
it. So
You have
is
all
it
of
all
it.
together? Is it one more than the other? We don't know. We're just
And
seeing it. We
nerves
observe.
too. I mean,
Yes, neuro. Yes, you
the
have
whole neuro
so
thing, because
much
yeah, the
involved.
skin is complex. It's one of our most active and, functional
Yes,
organs in a lot of ways. And again, we don't know what we don't know, but that doesn't mean that it's not true. It just means we haven't
right,
uncovered it
right.
yet. So, and I think doing that with the patient voice is so important. And that's why I launched T4P2,
Thank you.
the Constantine's tidbits with the patient perspective, because you guys need a seat at the table as we're coming up with these guidelines. You needed the seat at the table when we're coming up with treatment regimens, when we are coming up with all of these things. And again, I applaud you guys' efforts in trying to educate, trying to put the data together so it's palatable and easily digestible and backed by the best science that we can. And I do see just people's eyes are opening. So the work that you have done is being recognized by some, and I think it will be recognized by a lot more sooner than later because of the foundation that you have laid that now we need to build on together. And it's time to pick up our hammer and nails and help each
Yes.
other so that we can get there so nobody else has to suffer from this. So thank you so much, Kathy, for sharing, and again, I apologize that you've had to go through this, but I'm so proud of you for using the pain you've been through for a purpose. That's gonna really, I mean, change the world for a lot of kids. And again, getting those codes out there, that's not easy. All the regulatory things that you guys are doing, and I have to applaud your website. It is chock full. Like, please, all T4 subscribers, go to the ITSAN website. It's itsan.org,
Thank you.
ITSAN.org.
Yes,
Um,
that's it.
you have to go to it. They have great information. There's a whole tab just for doctors or medical providers. They have really served this to you on a golden silver platter, golden even, I don't know, whatever. It's really nice. It's nice. And there's literature out there to support it. And again, as healthcare providers, we need to care and we also need to have lifelong intellectual curiosity. That's why we went into this, and
Yes.
new data is
Yes.
going to come out. We know that it's coming out every day. And again, just because we haven't heard of it or we don't know about it doesn't mean it doesn't exist. So, um, again, Kathy, I thank you. And please, everyone, T4 prescribers, send your kiddos, the families, to ITSAN. They have a great community to support one another. There's really wise, smart, good people that are part of ITSAN. They're not wild and crazy and renegades. They're just not. They're normal people that have struggled, and want to help others. So again, that's the beauty of it. We are here for each other, and when we lift one another up, we all get better in the process. So again, refer early, refer often to ITSAN. If you have a patient that's concerned, listen, see, don't just, listen, 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 look, and use those skills that we've honed as dermatologists and healthcare providers so that we can make the world a better place. So again, Kathy, thank you, thank you, thank you, thank you for helping us spread the word. And I can't wait to see the next even year, 5 years, 10 years down the road. I think this is going to be a lot more known. Atopic dermatitis, there's going to be so much more known about it. There's going to be so many better drugs that are not immunosuppressive, that are more targeted. And there'll be more knowledge about this subset of patients and why does this happen in a subset
Yes.
and not others? And again, it's doing it together. So
Yes. Thank you so much for your help and for being, one of the good guys. We really, really, really appreciate it and this whole
you,
opportunity. And I just applaud everything you're doing. So keep
thank
going. Keep going.
Yay.
You're
You
helping
too. You
people.
too. We're in the fight
Thank
together.
you.
And as soon as hopefully not going to be a fight, we can all sit down and sing Kumbaya together.
Yes. That's the
That would be
plan.
much more fun, and eat
Yes.
bonbons.
That's the goal.
Thank you, Kathy. Have a great, hopefully you get a little nap in before you have to jump into your ITSAN work, or I'm sure you have kid duty and mom duty. So again, thank
Yeah.
you for making the time. We
Thank
appreciate it.
you.
All
Thank you.
right.
Okay.
Bye-bye.
Bye.